Okay, so our speaker today is Dr. Michael Mack, hence the song Mac the Knife and the Return of the Mac. And so Michael is, in addition to being a hell of a nice guy, an assistant professor in the Department of Psychiatry at the University of Toronto and is still an adjunct research professor here at Western. He is currently a staff psychiatrist at the Center of Addiction and Mental Health in the Critical Care and Crisis Program, but also more relevant to his presentation today, he practices sleep medicine at the Sleep and Alertness Clinic in Toronto. So Michael received his medical degree from Queen's University in Kingston and completed his psychiatry residency here in Toronto. He then did a fellowship in sleep medicine at Western and has received certification as a sleep medicine specialist. So today, Dr. Mack will be talking about sleep disorders and sleep abnormalities and sleep problems in people with developmental disabilities. So welcome back, Michael. I don't want to say you are the prodigal son, but perhaps that's not a terrible term. And so you take it away.
Hi, everyone can hear you.
No.
Can you hear me?
I can. Is that volume good enough for everybody?
You guys see the screen?
Yep.
So
apparently the sound is fine.
Yeah. So I lied a little bit. Like I said, it was going to be like a review of sleep problems and the DD population, but I already did that maybe 3 years ago. So I didn't want to retread. So we're going to focus in on the most common sleep problem in this population, which is insomnia. And I have to credit Dr. Nicholson for to sleep perchance to dream part. I would never be able to come up with something catchy like that. So in terms of conflicts of interest, I'm an investor in a home sleep apnea testing device, but otherwise I have no other conflicts of interest that are relevant to this presentation. So in terms of objectives today, at first we're going to visit the epidemiology of insomnia and sleep problems in the DD population. We're going to look then at pharmacological treatments and then subsequently psychological treatments. So, before we go about managing a problem, we have to define it and, to see if it's an actual problem, right? So in terms of definition, insomnia disorder, and when you look through the DSM, it's always about the same. The criteria A is going to show you some core criteria for the problem. So insomnia is defined as a problem falling asleep, staying asleep, or waking up too early. And if we're dealing with a pediatric population or a DD population, sometimes that's going to be done in that context. So as an example, problems falling asleep may manifest itself as problems falling asleep without the intervention of a caregiver. And same thing with middle of the night awakenings. As with all disorders, it has to cause a dysfunction in your life for it to become a disorder. So it's got to cause issues in your social abilities, your ability to complete school or your work. And the duration criteria is that you have to have these symptoms for 3 times a week for at least 3 months straight. So they made it actually harder to meet criteria for insomnia disorder when we switched over to DSM-5 from DSM-4-TR. The old definition was such that if you had problems, sleeping, falling asleep, staying asleep, waking up for 3 times a week for 1 month, you would meet criteria. Nowadays, it's for 3 months. And of course, your domicile, your sleeping quarters have to be decent enough that you can achieve sleep. And the problem can't be better explained by things like, other psychiatric conditions, the use of a substance or medical condition. So drawing at overall epidemiology. So right now I'm talking about insomnia disorder as it relates to the entire population, okay? So drawing on work from Maurice Ohayon, who's with the Department of Psychiatry at Stanford, who's the king of sleep epidemiology. When we look at the problem of problems, falling asleep, staying asleep, and waking up too early, that applies to about 30% of the general population. If you add a daytime dysfunction criteria to it, it's about 10% of all people. And if you add the duration criteria from DSM-4-TR 3 times a week for at least 1 month straight, then it's about 6%. So if we're talking about across the general population, if we use DSM-5 criteria, insomnia disorder is going to occur at some, it's going to be present at a rate of some number less than 6%. We know that insomnia is often comorbid with medical and psychiatric illness, and especially so with the DD population. Generally speaking, if it's present and it's not treated, it does follow a chronic course. It tends to stay unless there's an active, effort made to treat it. And it exerts a significant healthcare and occupational sequelae. So a fellow by the name of Charles Morin, who's with the Department of Psychiatry at the University of Montreal, he did a study looking at healthcare costs, direct and indirect costs of insomnia. So direct costs being, how much are we paying the doctors that see patients for insomnia? How much are the patients paying for medications? Those are direct costs. And indirect costs include things like loss of productivity, as an example, because the person that's sleepy isn't working as well as they should. So the number he came up with was $6.6 billion a year for just the province of Quebec. So this is a big problem for society as a whole. If you have insomnia disorder, you're much more likely to have a comorbid psychiatric condition. So here you see that if you have insomnia, the prevalence of co-occurring depression and anxiety is much higher than what we'd expect. Same thing with medical illness, and it's bidirectional. If you have one of these medical conditions listed here in the slide, heart disease, cancer, hypertension, urinary problems, diabetes, your risk of getting insomnia is much higher. So specifically for Canada, there's been a number of studies that have used population-based data. So in 2007, they did a telephone survey reaching out to people who were part of the census. So this is going to be speaking of people who are of voting age, and therefore applying to adults across the country. Using DSM-4-TR criteria, they found that about 13% of Canadians met criteria for insomnia disorder. And that lines up with the findings in an earlier study back in 2002, where they just mailed out questionnaires to people on the census. And that at that time, it was also around 13%. You'll notice that these numbers, the 13%, is a bit higher than the 6% figure that I cited before. And some folks have postulated it has to do with where our country is located. We're higher in the hemisphere and farther away from the equatorial countries. And therefore, our light exposure, across 365 days, on average, is going to be lower than equatorial countries. And you'll soon learn that light exposure is crucial for having a good sleep schedule. So specifically, as it pertains to the DD population, sleep problems occur in up to 89% of children with ASD, so that's autism spectrum disorders, 86% in folks with intellectual disability, and 65% in children with Down syndrome. And, these numbers are sky high, and it seems to persist to adulthood. The data shows, as you can see there on the slide, for adults, 45% about, 32% intellectual disability population, and 74% in the Down syndrome population. So, and in general, when you take a synthesis of studies looking at sleep problems in the DD population, we know that if a person has more sleep problems, they have more behavioral and psychological disturbances. So the most common sleep disturbances in the ASD population include things like a prolonged sleep latency, which is just, all it means is it takes you a long time to fall asleep. You're going to have more middle of the night awakenings, that's wake after sleep onset, or you wake up just too early, like waking up at 4 o'clock or 5 o'clock in the morning. That's early morning awakenings. And as a consequence, you have daytime problems, things like daytime fatigue. And, as is the case with the general population, the research shows that if we don't actively treat the insomnia or sleep problems as they occur, they do tend to persist throughout the lifetime. A lot of research reflects that insufficient sleep can lead to the worsening of core ASD symptoms, things like increased stereotypic behaviors, and increased difficulties as it pertains to social social skills, communication, and cognitive measures. There's an increase in self-injury, non-compliance with treatment, irritability, tantrum throwing, and aggression. On the other hand, the question that's been asked many times before is, are increased sleep problems, does that translate to a greater cognitive impairment? And the results from those studies are mixed. So we can't say if a person with ASD has sleep issues that leads to somehow cognitive difficulties. There's a number of ways that bad sleep can mediate, bad sleep can be caused in this population. So probably one of the strongest factors that's postulated is disturbed reception to circadian rhythm entrainment. So, we all have a circadian internal body clock, and it needs to be adjusted and entrained to the external light-dark cycle. The internal body clock regulates a lot of different bodily functions, things like when you're most alert, when you're going to start to feel sleepy, when you feel most hungry, when you're the strongest. And there's certain times of the day in the 24-hour day that it makes most sense to be good at one thing versus another. And, for your internal body clock to be set at an appropriate rate as it pertains to the external light-dark cycle, so that, when the sun is out, you're more alert, and when the sun goes down, you're more sleepy. The strongest entrainment factor is light. And we know that in folks with autism spectrum disorders, sometimes their sleep schedules become irregular. Some folks will have irregular sleeps during the course of a day. Instead of having one long sleep at nighttime, they may have 3 or 4 2 to 3 hour sleep periods during the course of a 24-hour day. So that's going to affect their exposure to sunlight or sources of light. And because in terms of the core criteria for ASD, that you're going to have some social impairment, they're not going to necessarily have the same amount of social contacts as a person without ASD would. And we know that socialization is one way that your internal body clock gets entrained to light-dark cycle of the external environment. We also know that in folks with ASD, there is certainly a lot of evidence that shows that their melatonin secretion, which is one of the main neurohormones that regulate the internal body clock, the secretion of this molecule is impaired. Sometimes they secrete very little of it, or the timing is totally off, or sometimes there's no secretion whatsoever. There's been some work looking into the genes that control the internal body clock proteins, things like, not to bore you with details, things like BMAL1, the period gene, and the clock gene. There's thought that maybe in folks with ASD, that there's a genetic component that leads to this problem of the circadian entrainment. And also the comorbidities that a person with ASD has can lead to sleep disruption. So things like gastrointestinal symptoms, comorbid seizure disorders, comorbid anxiety, and ADHD and the treatments of ADHD. So as an example, if a person has comorbid ADHD, the treatments are going to be things like stimulant medications, and stimulants can cause insomnia at nighttime and disrupt nighttime sleep. And of course, for behaviors, behavioral disturbances, the medications used to treat those symptoms can cause sleep issues. We know that SSRIs and antipsychotic medications upset the normal sleep architecture that a person can have. So these are different ways that we think insomnia can develop in the ASD population. So how do we assess sleep? It's going to be things like sleep diary, taking a good sleep history, asking the patient questions, doing a physical examination if necessary, actigraphy and polysomnography. So I'm going to go into details about each method. So the standard way to assess sleep, you're going to take a good sleep history. So asking the caregiver or asking the patient, when do you go to bed usually? How long does it take for you to fall asleep? Do you wake up in the middle of the night regularly? How many times does that happen? Are there specific reasons why a person wakes up in the middle of the night? What time do you get up in the morning? So that would be standard. And then also applying that information and putting it down onto a sleep diary so that you're serially tracking sleep habits of the patient. This can be done by the patient if they're high functioning enough to do so, or by the caregiver. And you would serially track the sleep habits over the course of, let's say, 1 to 2 weeks or even up to a month. And then that allows us to look at patterns of sleep and possible reasons why the sleep is interrupted. Actigraphy involves, it's a technology that's basically, it's in the form of a wristband, and it measures movement. And it uses the absence of movement as a proxy for sleep, being that, for most folks, when they're asleep, their bodies are relatively much more still than when the person is awake. So, that's an objective way to measure when a person falls asleep, when they wake up, if they have middle of night awakenings, and so on and so forth. And polysomnography, or a sleep study, that's optional. That's only used if there is a suspicion of comorbid sleep disorders outside of problems falling asleep or staying asleep. And that would apply to things like if the patient snores, there might be the presence of sleep apnea, if there's any restless legs or other sleep conditions. So those are the ways that we assess sleep. So these are examples of sleep diaries. On the left there is a more visual sleep diary that's provided by the American Academy of Sleep Medicine. If you look that up, American Academy of Sleep Medicine Sleep Diary, you can download that as a PDF and print it off and give it to your patient or their caregiver, and they can just shade off the blocks when the patient is asleep. So each block represents a time of day. It's 1 hour each. There's parts where you can fill in when they take medications, if there's been increased social activity, exercise, etc. The one on the right-hand side is going to be a little bit more hard to use. It's probably going to be done by a caregiver, but both are very good. So these are just examples of actigraphy machines. We tend to put them on the non-dominant hand. When we're studying sleep in the ASD population, one of the things that does come up is how these devices can affect the patient. So we know that in the ASD population that there can be a sensitivity to different stimuli, different tactile sensations, and having this band on the wrist isn't necessarily a comfortable thing for the patient. So in research studies, even that when they use actigraphy as an objective measure, we do see a lot of dropout. So if the patient is able to tolerate it, that's great, because now you have some objective evidence. But the patient self-report through the sleep diary is also good enough. But if you can do both, it's even better. So this is an output from an actigraphy machine for a person that has normal sleep. So you'll see that in the areas highlighted in blue, there are very few vertical black bars. So vertical black bars are representative of movement. So in those relative periods of no movement, and you'll see that at the very top here, it's going to be hard to see for some folks, it's actually time. So in the middle here, if you can see my cursor, that you'll see that this bar here is gray and this bar here is yellow. So when it's yellow, it means that those are the times when the sun is out, and this is nighttime when the sun is down. So this person appears to be sleeping normally during periods of darkness in the external environment. So this would be the actigraphy output from a person with irregular sleep schedules. Some of the times we do see this in folks with ASD. This person is sleeping during the daytime. Sometimes they're sleeping at night, but it's not necessarily continuous, and the durations vary from day to day. So looking at common comorbidities, one of the most common comorbidities in terms of sleep disorders in folks with insomnia or sleep problems in this in this DD population would be the sleep apnea. So as you can see here, in ASD, there's a higher rate of sleep apnea compared to age-matched controls. We also see that for the intellectual disability population, there's a tendency for greater incidence of overweight and obesity, which we know mediates one's risk of sleep breathing disorders. So because they have a higher rate of overweight and obesity, they do have a higher occurrence of sleep apnea. This is most pronounced in Down syndrome, where in the child population, you're seeing 50 to 100% of those kids with sleep apnea, in adults up to 94%. That has to do with the phenotype, the physical phenotype of Down syndrome, because what we see is they often have they have a short neck. They also have macroglossia, which is having a big tongue. And, these structures having the big tongue leads to an easier chance for the airways to close up, and therefore they have a very high chance of sleep apnea. So these are things that we need to watch out for. We need to be, keeping the back of our heads. And if we see the symptoms of snoring, if the person looks like they're very sleepy during the daytime, maybe we should send them for a sleep study. There's been many studies looking at sleep architecture. Once we send a person with ASD for a sleep study, we're taking brain waves and EEG during the nighttime, and the characteristic differences in the ASD population compared to the general population is the following. So SE represents sleep efficiency, meaning that represents, so that's the proportion of the amount of time that you're actually sleeping divided by the time that you're lying down. So if you sleep 8 hours and you're lying down for eight hours, you have perfect sleep. Your sleep efficiency is 100%. But let's say if you lie down for 8 hours, but you're only sleeping for 4 hours, then your sleep efficiency is poor. It's 50%. So we know that in the ASD population, the sleep efficiency is lower than the general population. The general population average would be around 80%. We know that in the ASD population, there's also a lower proportion of slow wave sleep or deep sleep. And that has some implications to physical health, because we know that in slow wave sleep, that's the time when the body releases the bulk of its growth hormone, which is involved with growth, muscle, and bone repair. It also takes them a longer time. They take a longer time to fall asleep. They have a greater proportion of light sleep, and they have more middle of the night awakenings. One interesting finding is that they have lower REM density, which just means you can measure the amount of eye movements, rapid eye movements in dream sleep, and divide it by unit time. In the ASD population, the eye movements in dream sleep occur less per unit time. The significance of which we're not entirely sure of, but in general populations, if you have high REM density, that's associated with major depression. So a lot of work is being done to look into the architecture of sleep, the microarchitecture of sleep, etc. The last finding that's very interesting is that in folks with ASD, there's a much greater prevalence of a finding called the loss of REM atonia. So, when we dream, our bodies are totally paralyzed. We never act out our dreams. We don't move around in our dreams. We're not normally acting out our dreams. So, however, like in many studies looking at ASD population, in one study, it was up to 72% of people studied in the sleep study that had movements in dream sleep. This is something that we have to keep an eye out for, because in the general population, if you have the loss of REM atonia on a regular basis, that can be associated with alpha-synucleopathies. So things like Parkinson's disease, multiple system atrophy, and dementia of Lewy body dementia. So, continued work is being done to see if this finding mediates that risk in this population. So we've defined the problem. We know how to measure it. How do we treat it? How do we treat this insomnia with medications? So first off, I'll just do a quick review of what circadian rhythms are. I already talked about it a little bit earlier. Basically in the course of a 24-hour day, your internal body clock mediates a lot of bodily functions. So depending on the time of day, you're going to have differences in your alertness and sleepiness, your coordination, your balance, your reaction time, your strength, your blood pressure, how hungry you are. And of course, like I mentioned before, the things that entrain our internal body clock so that it syncs up with the external light-dark cycle is light, and light is the strongest factor. Other things include eating, drinking, socialization, temperature, and sound. So if we take a person and we measure their their melatonin levels, we'll see that it starts to be secreted by the pineal gland in the brain right when the sun goes down. So around 7 to 8 p.m. peaks around 2 to 3 o'clock in the morning, and then as the sun comes up, or around that time, it decreases to negligible levels. And we know that it's the onset, the secretion of this melatonin, that is the cue for our body and mind to feel sleepy and to go to bed and to sleep. So the melatonin mediates sleepiness. So a lot of, when we look at melatonin secretion in folks with autism spectrum disorder, we see that their nighttime secretion of melatonin is much lower than age-matched controls with no ASD. And when we study folks with low melatonin secretion, we know that they will have impaired sleep. They'll have symptoms of insomnia. Sometimes the time when they feel sleepy is going to be totally off. So instead of feeling sleepy at maybe like 10 to midnight, they might start to fall. They might naturally only start feeling sleepy at 4 or 5 or 6 o'clock in the morning. So the overwhelming evidence shows that in people with ASD, their nighttime secretion is too low. So this is what the slide is demonstrating. And in this particular study, they also did, they correlated melatonin levels with the results of the questionnaires that they used. So one of them was the ADI-R, so the Autism Diagnostic Interview revised version. And what they found was that higher levels of nocturnal melatonin negatively correlated with autism severity in things like verbal language, imitative social play, and repetitive use of objects. So they're implying that in the folks with the lower melatonin levels, they had higher symptoms, negative symptoms of autism. So this is an interesting study. This further stratified, the groups of people with autism as compared to controls. So they were able to enroll folks with ASD that had comorbidities, things like depression and anxiety. So that's the ASD med group. So these are folks with autism plus depression or any anxiety disorder. And ASD only is self-explanatory. These are patients with only ASD and no psychiatric comorbidity. And then obviously they have the controls here. So in this study, what they found was that in the group that has autism spectrum disorder plus the psychiatric comorbidity, they have an attenuated and inappropriately low melatonin secretion. So this is represented by the bottom line here. And these are secreted at levels that wouldn't be able to affect sleep in a normal way. You'll see here that in the ASD only and the control group, the curves are very similar. So this melatonin onset or secretion would be sufficient to exert a pressure to sleep at the appropriate time. So, what this is quite interesting because perhaps there's differences in the ASD in folks with ASD with the psychiatric comorbidities versus those that do not. And this might be reflected in patients with ASD and psychiatric comorbidity as having worse sleep as opposed to ASD only. So moving on to treatment. So if you're endogenous, your internal melatonin secretion is not going well, like as we've seen in the slides before, then the treatment is exogenous melatonin. So going to the drugstore, buying some melatonin, taking it as a medication. So this is a very high quality study. So a publication in the British Medical Journal, a randomized double-blind placebo-controlled trial, so level 1 evidence. Sorry, not level 1 evidence, but at least it's double-blind placebo-controlled. Basically, they took folks, kids with ASD plus insomnia, and they either randomized them to the melatonin group or a placebo group, and they found significant differences in terms of report by the caregiver. So significant decreases in the time it took for them to fall asleep. So an absolute, like a decrease, absolute decrease of 37.5 minutes in the melatonin group versus the placebo group. And there was also a statistical significance in increase in the total sleep time. So it's nice in this study, what they did was they also double checked it with actigraphy, right? So that's like that thing they wear in the wrist to measure objective sleep times and wake times. And obviously you'll see that there was some drop off. Some young folks in the study could not tolerate the actigraphy, but the total sleep time in the actigraphy side, there was no statistical significance increase in the total sleep time, but there was a significant decrease in the time it took for them to fall asleep. So you can see that right here, minus 45 minutes. So that's a good chunk of time. I hate it when I go to talks and then they talk about medications and there's no guidance in terms of dose ranges. You know, for this to be pragmatic, you know, we need to have some numbers here, right? So what were the doses of melatonin that they were giving to these kids? So you'll see them here in this table. So there were 4 options in this study. The lowest dose is 0.5 milligrams. Caregivers were asked to increase the dose to effect. So if you took 0.5 and that was good enough, then you stayed there. But if it wasn't, then you would escalate the dose all the way up to 12 milligrams. So it's 0.5, 2 milligrams, 6 milligrams, and 12 milligrams. And this study occupied 12 weeks. And you'll notice that they had a 4-week period when they were allowed to escalate the doses. But, you know, even at 0.5 milligrams, about 1 in 5 kids responded and their sleep improved. So I think that, you know, this tells us that we could try giving low dose melatonin, 0.5, and maybe all the way up to even 12. So does melatonin, we know that the melatonin helps with the sleep side of things. Does it help with the behaviors, negative behaviors associated with ASD? So the answer is that the evidence is mixed. Some studies show improvements, especially as it pertains to irritability, violent outbursts, tantrums, but most of it is very mixed. If we're cherry picking studies, there was one open label study that showed reduction in stereotypical behavior, compulsive behaviors, and hyperactivity. I think that we can't say that this is something that we can expect. For now, I would say melatonin does not improve behaviors. So what about melatonin in the intellectual disability population? So we do see good effect as well. So this is another high quality study, randomized placebo-controlled study. And we see that there's a significant decrease in the time it takes for the patients to fall asleep. There's an increase in the total sleep time and reduction in middle of night awakenings. So, you know, I changed the slide and you didn't see anything for Down syndrome. And it's because there's actually no good studies for the effects of melatonin in sleep for Down syndrome. We do know that in folks with Down syndrome, there is a higher presence of circadian rhythm disorders and melatonin secretion abnormalities, but there just isn't the data there. So the last bit, we're going to focus on behavioral approaches to insomnia. So, you know, the behavioral treatments to insomnia, what's termed cognitive behavioral therapy for insomnia, is the gold standard treatment for problems falling asleep or staying asleep or waking up too early. For the reason it's not a medication, therefore has no side effects. I mean, even with melatonin, common side effects that people do complain about are next day sedation, headaches. Some people will say if you've taken it and a person wakes up to use the washroom, be careful that they don't fall. Because the psychological therapies have no side effects, you know, this is often very advantageous. And the other thing is that what we see is that the gains are durable, meaning that when a person completes the course of the behavioral treatment, generally speaking, the insomnia tends not to return.
Michael, if
yes.
I can interrupt, there was one question, I think, about the previous slide about melatonin, about whether it was immediate release melatonin or was it delayed release, or do you know?
Immediate.
Okay.
Yeah. So in terms of, you know, if I had to choose, which one would I do first? You know, behavioral versus medication. I would say do the behavioral intervention first, because the efficacy is equally as good as melatonin, if not better, and the gains are durable, and you're avoiding taking one extra pill. And in the American Academy, the American Association of Neurology, they actually have a guideline for the treatment of insomnia in folks with ASD. I don't know why they were put in charge of, doing those guidelines, but they actually also recommend either a combinational approach where you do melatonin and a behavioral treatment, or the behavioral treatment alone. So basically, when it comes to insomnia, when patients have difficulties falling asleep or staying asleep, oftentimes there's going to be a behavioral component to it that perpetuates it, no matter how it started. And insomnia can start from any number of factors. Going to a new school, going from a smaller class size to a bigger class size, having one set of resources and losing them. The thing is that there's always behaviors that are attached to the insomnia that keep them there. So, oftentimes we now see people, occupying their time playing video games, especially if a person exhibits, a special interest in playing video games or electronic devices, and that's becoming more and more popular. That can affect nighttime sleep, right? So, the behavioral approaches reduce the medication burdens. The way that we understand insomnia and how it develops is, well, we all have a predisposing level towards insomnia. There's always a predisposition that might be genetic, right? But no one's ever born with insomnia. No one's ever born such that they have difficulty sleeping 3 times a week for 3 months, and causing them, daytime impairments. The idea here is that we're going to reverse the behaviors and the thought processes that go behind the insomnia to bring you back to your genetic level. So we know that this is just a reflection of what I said before. All the studies for the behavioral treatments show that it decreases the time it takes for you to fall asleep, reduces middle of night awakenings, increases total sleep time, as well as any sleeping pill. And there's different ways to get it. I think classically, you would see a face-to-face therapist, but when they've studied it, using alternative delivery methods, things like, reading the textbook, electronic versions, online versions, virtual versions, or even shortened brief formats, they've been shown to be essentially non-inferior. So what, people always talk about behavioral therapy for insomnia. That's the best thing. You should get it. What is it made of? Well, it consists of sleep restriction, stimulus control, relaxation interventions, cognitive restructuring, and sleep hygiene education. So, these are the basis of the behavioral treatment for insomnia. And the key here is that, you need to apply the program so that it's going to work for the developmental level and the cognitive level of the patient you're giving it to. So in some patients with Down syndrome or higher functioning autism spectrum disorder, they can take on the full usual program that's delivered to adults. If the person's cognitive levels are more impaired, then they have to be adapted so that you're going to do the teaching through other means, sometimes through visual calendars, through icons, through game playing. So let me just go through the different aspects here. So there's always going to be an element of what we call sleep restriction. And basically what we're doing is we're decreasing the amount of time that you're going to be actually lying down and trying to sleep. Because, by definition, if a person has insomnia, they're going to be lying down wide awake for some amount of time, probably an hour or maybe 2 or maybe 3. So we're going to ask the person not to lie in bed, as much as they can. So like if a person is lying in bed for 8 hours, but they only sleep for 6, then I'm going to tell them to push their bedtime later by 2 hours. They're not losing anything because they're wide awake for 2 hours anyway. I'm just getting them to stay up for a lot longer. And this provides that extinction, the extinction of taking away the bed's association with wakefulness. And it also drives your internal need for sleep higher, right? So it's axiomatic that if a person stays up for 16 hours, that person is more sleepy than a person that's been awake for, let's say, 12 hours.
So, Michael, just a couple of questions. So one question from, I assume, Dr. Ogilvy about the sleep hygiene and the behavioral interventions was about the age range of the behavioral interventions that you were talking about. So is this for adults or children or both?
So this specific, these principles are going to be the same for all age ranges. There are different, delivery methods. So there's cognitive behavioral therapy for insomnia. There's cognitive behavioral therapy in childhood insomnia. So CBT-CI. The principles are all the same. The delivery methods are going to be different. If you're dealing with like a child population, as an example, with the timing of sleep and stimulus control, you're going to try to explain it to them in a more visual way. So, drawings, having a visual representation of a day and night, what you might do during the day, like a moon and stars for nighttime. If you look up cognitive behavioral therapy in childhood insomnia, there's these supplemental materials in some studies, and they show you what they use. But there was so much of them that I didn't want to include it here because it would take 3 hours to talk about it all.
So do you think does what you've presented, does it apply to toddlers also, or are we talking more school age and up?
School age and up.
Okay. So the other question, which came from our colleague Vikram Palanasimi, I'm sure I butchered your name, Vikram, I apologize, who has joined us all the way from the west coast of Canada, is around any trials comparing medication versus behavioral intervention.
Most of the vast majority of studies have been it's all mixed up because what they do is they show like a melatonin group and then a melatonin plus CBT group.
So do they have a CBT group by itself, or typically not?
There's very few studies looking at that, but like in those studies, the CBT by itself was equal to CBT plus melatonin.
And do those groups have a placebo? Do those studies have a placebo group?
No.
Okay.
No. I think the problem that keeps coming up is how to enroll people, because the studies suffer from a lot of dropout. So it's very hard for them to study. In adults, they do have those studies with the necessary placebo groups, and they all show superiority of CBT alone. Like the melatonin, the melatonin's better than placebo, but not better than just CBT alone.
In intellectual disability population, are you aware of any studies comparing medication with behavioral interventions?
Directly, no. It's always mixed up. There's always a mixed group.
Okay. So Vikram, that field apparently is wide open for you to do that study. Catherine, I'll ask Michael later on to answer your question, and we'll come back to the other questions later on.
Okay. So stimulus control is just a process where we're seeking to adjust the sleep time so that it lines up with the external light-dark cycle. So getting the patient to go to bed only when they're feeling sleepy. You can't have a fixed bedtime or a sleep time every single night because depending on what you did during the daytime, you're going to be sleepier on one day versus another. So if let's say if it's a kid, they went to school and or they had a lot of physical activity. You went to the park, you brought in your neighbor's pet, you're playing. That day that has more physical activity is going to lead to an earlier sleepiness time. And then on a more relaxed day, you're not going to feel sleepy necessarily as early as you would otherwise. So going to bed only when you're sleepy is the best way to proceed. But the thing is that you should wake up every single day at the same time, because your time of first light exposure in the morning is actually what starts the about 24-hour circadian rhythm internally. It's that first light exposure of your melanopsin receptors in your eyes that go to the suprachiasmatic nuclei that sets up the stage for when you're going to feel hungry, when you're going to be the strongest, when you're going to feel sleepy later on. So waking up every single day at the same time and only going to bed when you're sleeping. Of course, no daytime naps whatsoever, because if you have a nap during the daytime, that takes away that pressure to sleep at nighttime and interrupts nighttime sleep. There can be different relaxation therapies administered. So this is probably something that you're going to do with a more higher functioning population, maybe some folks with Down syndrome or higher functioning ASD. So, the relaxation therapy just seeks to reduce sort of physical stress and mental stress. And they include things like progressive muscle relaxation, autogenic training, guided imagery, things like that. And then, of course, just some brief talk about cognitive therapy. Whenever they've done comparative studies looking at, okay, if we give a person CBT with all the factors, including cognitive therapy, and let's give them CBT with no cognitive therapy, are the outcomes different? Generally speaking, it doesn't seem like the cognitive therapy plays a significant role in improving nighttime sleep, but you're just seeking to dispel some adaptive sleep beliefs. You're not going to die from insomnia. You can't attribute, all the problems in your daily life or behavioral outbursts just to the sleep problems itself. This is going to be applying more for adults and more for the Down syndrome population. So sleep hygiene, everybody knows about this. This is highly emphasized in medical education as an example, but by itself has never been shown to treat insomnia with any efficacy by itself. Most good sleepers will have good sleep hygiene, but just because you get good sleep hygiene doesn't mean you're going to have good sleep, okay? So, these are points that I think we're all aware of. Avoiding smoking several hours before bed, avoid drinking alcohol or caffeine several hours before bed. Exercise, that's great, but don't do it too close to bedtime. You always want to make sure that the bedroom is quiet and cool and dark. So this is a great paper, okay? Because they spell out basically a trial of a behavioral intervention specifically designed for children with ASD. And they've taken all those concepts that I talked about in the 5 slides previously, and they've condensed them in a way that can be applied to children with ASD. So there's 2 components that they utilized. The first factor and the more effective factor was what they called bedtime fading, which is a combination of sleep restriction and stimulus control and positive routines. And I'll go into some detail now. So I because the material is so good, I couldn't just paraphrase it. I put it here. So the bedtime fading essentially is you're doing sleep restriction and stimulus control together. The caregiver calculates the average sleep onset time. So, over 2 weeks, okay, what's the average time that the kid actually goes to bed and falls asleep? So let's say it's 9:30. Then what you're going to do is you're going to add 30 minutes to that. So you're going to get them to you're gonna push the bedtime such that you're going to push the bedtime later by 30 minutes, such that afterwards you're going to measure how long it takes for them to fall asleep and see if it's going to be 15 minutes or less. And what you're doing is that you're pushing the sleep time either earlier or later until you reach the goal of having 1 additional hour of sleep time at nighttime and having a sleep latency, the time it takes for you to fall asleep, of either 15 minutes or less. So, that's a combination of the sleep restriction and stimulus control. So getting the average sleep onset time, adding 30 minutes to it, measuring the sleep latency for the next week. If the sleep latency is less than 15 minutes, then you can expand the sleep window by 15 minutes until you reach this extra 1 hour plus a sleep latency of 15 minutes. If not, if the sleep latency is more than 15 minutes, then push the sleep time later by 15 minutes. They also tested a separate intervention they called the positive routines. Basically, they added this 30-minute routine prior to the bedtime. There were activities such as dressing, washing, and story time, brushing hair, etc. They sort of modeled positive routines after studies and trials that they've used, methods that they've used to decrease nighttime tantrums in patients. So I've outlined it here. Basically, just having a consistent routine before going to bed with appropriate social reinforcing. So what they used was a visual schedule containing pictures of all the routines that they would do all the way up until the child is put into bed and the parent leaves the room. I've outlined them here. So I don't want to just read off the slides, but they're here so that you can take a look. And I want to show you that the bedtime fading was very effective. Okay, so on the left-hand side here, the concept of the bedtime fading, as you can see, decreased the sleep latency in the 3 individuals in this trial. The total sleep time is on the right-hand side. That was increased in absolute numbers as well. This is the positive routines group. So the success here was a bit lower compared to bedtime fading. These were the results essentially. So total sleep duration was increased, sleep onset latency was decreased in bedtime fading, but with positive routines it was more mixed. They did get some decreased sleep latency and increased total sleep duration, but only 2 to 3 participants. I know that this is a trial where the N is 6, but it's very infrequent that a clearly clever designed sleep program is sort of shown in all its steps. And I think that this is something that might be helpful pragmatically in practice. So insomnia, we're going to evaluate it. Sleep problems, we're going to evaluate them with sleep diaries and actigraphy. Those are probably the standard and best choices. If we're thinking about medication treatments in the developmental disabilities population, melatonin is the one with the best evidence. And behavioral approaches, they certainly work. I would consider them superior to medication approaches. You're going to tailor them to developmental and cognitive abilities of the patient. So that's the presentation.
Michael, thank you. That was a wonderful and really timely review. Actually, that was fantastic. And the number of questions, I think, attest to the fact that it really raised a lot of interest in people. So so several questions. So first of all, Dr. Pryor had asked if you can recommend any good quality online CBT program for sleep for people with autism who don't have an intellectual disability. And
Yep.
I mean, you can always email it to me and I can email it to Catherine if that's easier.
I can spell it out to you guys right now. So now, has there been a trial looking at ECBT for intellectual disabilities populations? There isn't a trial like that, but if you're high functioning enough, if you can understand the words, this can work. So it's sleepontario.com/login.php. So that's actually a free course of cognitive behavioral therapy online. And that was developed by Colleen Carney, who's a psychologist, a professor of psychology at Ryerson. She's considered to be one of the finest minds in insomnia research and clinical care. She actually wrote a textbook that most people in North America use to learn CBT for insomnia. It's called Overcoming Insomnia. It's written by this other fellow named Jack Ettinger. So she actually came up with the content of this online course. So sleepontario.com/login.php.
Thank you, Michael. So next question then is from Professor Dr. Julio Martinez Trujillo. So some children with autism rock themselves to fall asleep. Is there any evidence that repetitive vestibular stimulation improves sleep in typical individuals or in individuals with other sort of neurodevelopmental disorders?
In neurotypical populations, I would say that repetitive motions, there's been no evidence that helps sleep. I don't think there's any specific trials or studies looking at the developmental disabilities population, whether that helps sleep or not.
And then, so I'll just pass on everybody that Dr. McLean very helpfully recommended a program called Better Nights, Better Days for children with neurodevelopmental disorders. I guess it's an online program by Penny Corkum and Shelley Weiss. And the URL is in the chat if people would like to look at that. So Dr. Cortegino from Children's Hospital and London Health Science Center said in talking about behavioral interventions raised the question of have you found the parents of children with autism or intellectual disabilities and things like that, in talking with them, what has been their willingness or reception to the idea of reducing time in bed, given that may mean less of a break for them?
It's always met with skepticism. I would say that, a lot of these suggestions that I make, that I tell patients to do, are, it seems like it's like the total opposite of what they'd expect to be told. But, I think psychoeducation is the most important thing. You have to explain that, these suggestions don't seem to make sense at first. And obviously, and there are studies actually that show that the parental sleep, like parents with children with ASD, the parental sleep quality is very, very poor. That, at first glance, like this is going to, be bad for them, bad for their sleep, bad for their kids' sleep. But that if they stick with the program, this is the evidence. The evidence shows that this is going to help. So it's going to get a little bit worse at the beginning, but it's going to get better later.
Thank you. So, by the way, just a reminder to anybody who wants to, that if you want to raise your hands, we can actually take auditory questions instead of constantly listening to my voice. So from Dr. Mitchell had a couple of points. So thank you for the talk. It's very relevant and important. So she says here, firstly, you backed up her theory, we'll call it the Mitchell theory, that some of the sleep difficulties in kids during the COVID lockdown were due not only to decreased physical activity, but also decreased social interaction. And she says also that she's known kids who were, quote, born with insomnia, at least that's what their parents report, and it's very common in the FASD population. And seems to improve with time, perhaps, rather than any particular intervention. So the intervention, I guess, is the tincture of time. But her question is, would you recommend for children, what do you recommend for children if melatonin and behavior therapies do not work? And then it says FASD, and she says, ignore the last FASD, that was a typo. I don't know how FASD can be a typo, but anyway, it's a very specific typo.
There's a meta-analysis looking at like efficacy of melatonin. There's actually studies looking at FASD, like fetal alcohol syndrome, right? Like and sleep problems, and actually like the melatonin was shown to decrease sleep onset latency in that population anyway. For a patient that's like treatment resistant, it sounds like did you say behavioral approach and medication approach didn't work?
Sorry?
Like was the question like, what I would do, and if the patient doesn't respond to melatonin, does not respond to behavioral approaches?
Yep.
I think that that's a situation where you're going to want to get a sleep study, and we don't know if the patient's going to be able to tolerate it, obviously. But if that's possible, that's the step I would do. In lieu of that, I would try the Actigraphy to look at some objective findings, sleep onset and sleep offset. And then, as last resort, medications. I mean, in this specific population, like medication-wise, there's always a lot of concern about benzodiazepine receptor agonists, because we do see a greater incidence of paradoxical outcomes when people take things like benzodiazepines or zopiclone, that there's an actual agitation as opposed to like a relaxation and increased sleep. I think off-label, you would want to do things that are relatively safe. So, all the guidelines in all of Ontario and in all of North America, essentially, they say that, don't prescribe sedating antipsychotics to young people for insomnia, for primary insomnia at the very least. But I would try an off-label experimental low dose of that.
Yeah, I think especially because if parents have tried everything, as Claire suggests, and are still desperate, that I think we recognize that things like Nozanan may not be ideal, but I think if people are at their wits' end, I'm not sure what the alternative is always.
The other options, like there's going to be newer toolbox, like tools in our toolbox in the near future. Like in terms of sedative hypnotic medications, we have a new class of medications called dual orexin receptor antagonists, and they block the molecule in the brain that's basically it blocks the molecule in the brain that keeps you awake. In people with narcolepsy, they actually don't have enough orexin. So in this compound, they block orexin, and it gives you like this, like, you know, increased need for sleep, right? So obviously there's no trials looking at kids. I would see that, you know, given enough time, if let's see how adults respond to it, you know, at some point, I'm sure people are going to do trials, right? Experimental trials, or, you know, in the younger populations and specialized populations as well.
Because modafinil is an orexin agonist, is it not?
No, like I'm not sure if there's any orexin agonists right now. Modafinil is just it's a non-amphetamine, non-methylphenidate stimulant.
Doesn't it work on the orexin system also?
I think it's more of a dopamine.
Okay. All right.
Yeah, but not directly at the dopamine receptor.
So there's a question here from Faraj Haddad, which is, it sort of goes to something I had wanted to ask, and I don't know if Nicole Neal is still here, but she might want to weigh in around sort of genetic mutations associated with sleep. And we know there are some. So people with Smith-Magenis syndrome for sure, which I think is on chromosome 17, but it is outside of the the sleep problems with Down syndrome because of sort of the shape of the neck and the oropharynx. I mean, are there any other genetic syndromes that we know of that, or genetic mutations that are linked to sleep problems?
Fragile X, but you know, that's comorbid with autism. I think the ones that I've spoken with are the ones with the most research done. Like I can't claim to have encyclopedic knowledge of, you know, how serotonin is manufactured in various genetic abnormalities, but these are the ones that I'm certain about.
Do you know, have you dealt much with people with Smith-Magenis syndrome?
No.
Because I think sleep is one of the primary problems in that condition. I think, and I think it's on chromosome 17, but maybe it's 19. I'm not sure. If somebody knows, please correct me. But I think sleep is one of the primary problems, and I'm not sure exactly what genes are in that area. But I think it has something to do with the release of endogenous melatonin. Actually, is the issue. Sorry, go ahead.
There's specific genes that have been implicated, you know, as to why the melatonin secretion or the metabolism, or, you know, reactions towards melatonin or abnormal or disrupted. So it's those genes like the PER gene, PER, period gene, and then there's BMAL1 and the clock gene, and they do see differences in even like the nucleotide sequencing. When you look at a person with abnormal either melatonin secretion or normal reactions towards secreted melatonin. So, you know, one wonders if that's associated with developmental disabilities. I can't claim to know that knowledge though.
So just a reminder, people, that, you know, it is 5:05, 5:06, and if I'm, as long as Dr. Mack is willing to stay here within reason, we can keep going. Let me, Nicole, do you want to say anything about Down syndrome and sleep? I will let you talk if you would like.
I don't know that I have anything more to say than what's been already said. A lot of families come with complaints, and the apnea is a problem, right? Especially. So Michael, just to give some back. So Nicole is a psychologist in the Faculty of Education, but her research essentially is entirely largely on people with Down syndrome and sort of early intervention. And so that would be but I mean, Nicole, because to be honest with you, I wasn't aware that people with Down syndrome had a higher rates of sleep problems, which is embarrassing to admit. But I mean, Nicole, do you have any sense of what percentage of parents complain about it? Oh, I honestly feel like every parent comes with it, to be completely honest, that I've experienced in some way or another. You know, whether it's like physical kinds of issues or just the whole routine of going to sleep.
Okay, thank you, Nicole. That's great. So another question from the left coast of Canada. The question about I see trazodone, quetiapine, and mirtazapine used often in sleep. What are your thoughts?
Those can be reasonable choices. Like if we're talking about, like, let's say adults, for example, when you look at the guidelines for medication treatments for insomnia, they advocate believe it or not, for things like, Z drugs to be tried first, things like zopiclone, things like zolpidem. And then in the United States, they say try the synthetic melatonin agonists, so Rameltian. They have activity at MT1 and MT2 receptors. So it's different than just over-the-counter melatonin. The binding affinity to those receptors are different, such that they actually have a greater hypnotic effect for whatever reason. If we get over-the-counter melatonin, it's not really a sleeping pill. It doesn't knock you out so much as it changes the onset of your sleepiness, right? But there's something about the synthetic agonists that causes them to have more sedative hypnotic effect. So those would be first line, and then afterwards you would try the sedating antidepressants, like you said, trazodone. And then, doxepin would be part of that now too, because doxepin is the only medication indicated for middle of the night awakenings in Canada. Trazodone is relatively safe. Obviously, I mean, they use it in for the treatment of off-label for the treatment of behavioral and psychological symptoms of dementia. The only things you need to watch out when you give that is if it's a male patient, if they're post-pubertal, you're going to warn them of priapism, which is a surgical emergency. Orthostatic hypotension, and it can cause QT prolongation, right? We're dealing with a population that has a higher psychiatric comorbidity. If they're on escitalopram or citalopram, those prolong QT as well. And if you add the trazodone to that, if you didn't check the QT, that could be a recipe for disaster.
So, Michael, if there's a recommendation against using sedating antipsychotics, why is it okay to use sedating antidepressants?
It's because of really the problem when it comes to the metabolic burden, with the olanzapine and Seroquel, olanzapine and quetiapine, those being the most commonly used sedating antipsychotic medications. You're looking at significant weight gain year to year if you take it every single night. And the problem is that if a sleeping pill works, there is a tendency for folks to continue to take it, and you don't want to give them that additional burden of diabetes risk, hypertension, other cardiovascular problems. I think that's really where the problem is.
So Dr. Kwiatkowski had a question actually about insomnia. So obviously, because that's the topic of the talk. But so it says here, treatment for insomnia in primary care in typical adults apparently has moved away from the use of melatonin, and in many cases advised against the use because there may be an extinction in terms of its efficacy for insomnia in the developmental population with age. Is there a transition age? Do you think that people should be doing trials without melatonin in children who've taken it for extended periods?
That finding's reflective of the physiologic phase advance that we see of all kids. You'll see, in one of my earlier slides, I was showing the prevalence of insomnia in children with either ASD, intellectual disability, or Down syndrome, and then moving on to adults. For ASD and intellectual disability, the prevalence drops, and it's because physiologically speaking, all primates, teenage primates, young primates, have a tendency to sleep late, wake up late, and then as we get older, the melatonin secretion actually happens earlier. So in the subset of the patients that have sleep issues, because their melatonin secretion is later than it should be, those people with time eventually get better in adulthood. So, I think that the melatonin all the way up until adolescence and early adulthood is a good first choice. If you're talking about a person who's 35, efficacy is going to be lower probably.
And there was a study published by Bob Findling from the Cleveland Clinic, I think, in the American Academy of Child and Adolescent Psychiatry journal a few months ago, where they looked at children with autism who had taken melatonin for 2 years, I think, sort of as an extension of a placebo-controlled study. And they found that over at least a 2-year period, there was no significant evidence of side effects, but also no loss of efficacy in people who had previously responded to it. So a couple of interesting questions. So one, in people who are congenitally blind who have also been diagnosed with autism or intellectual disability, is there any particular special considerations?
Well, with congenital blindness, sometimes they can suffer from circadian rhythm disorders by virtue of that. It really depends on, obviously there's rods and cones, which are the receptors in the eyes that are responsible for vision and color. There's going to be the melanopsin receptors that respond purely to entrain the circadian rhythm. If the optic nerves are intact, and they're still reaching the brain and the suprachiasmatic nuclei. We do see some proportion of blind folk that can still entrain despite not seeing the light, not seeing color, not seeing objects and outlines and forms. However, there is a significant proportion of people who are blind that suffer what's called non-24-hour sleep-wake disorder. And it's because our internal body clocks evolved at a time when the 24-hour cycle wasn't exactly perfectly 24 hours. It's 24.17 hours. So without light entrainment on a daily basis, when I wake up, I would sleep later and later and later. And given enough time, I'd be sleeping backwards. So that's what happens in all folks with the blindness, where there is also cortical blindness that affects the light entrainment of the circadian rhythm, in which case those folks must take exogenous melatonin to entrain their internal body clocks.
So there's several comments from the pediatricians in the audience about other genetic syndromes associated with sleep abnormalities besides Smith-Magenis and Down syndrome. And I think the other syndromes, it may be more of a central problem as opposed to a fits like a mechanical problem. But so apparently people with Rett syndrome and Prader-Willi syndrome as well have increased rates of sleep problems. So a question about sort of older adolescents with sort of profound sleep disturbances that haven't really responded to treatment. Is it ever reasonable to just let them sleep whenever they want to, sort of randomly, in order to get some sleep?
I think an initial effort should be made to regulate sleep so that they are sleeping at nighttime and then staying awake during the day. That's to their benefit, just so that socially speaking, banks are going to be open at a certain hour and closed at a certain hour. Schools, same thing. Places of work, even seeing your friends, right? Like most people are going to be up when it's light out, and they're going to be asleep when it's dark out. I think an initial effort should be made to regulate the sleep cycle so that we try to consolidate it at nighttime when it's dark out, so that they have the alertness during the day. If that doesn't work out, then it may be something that has to be accepted.
So there's also a number of questions, Michael, about other medicines, so things like clonidine, tryptophan, and things like that. I mean, in general, would recommendations about those be similar to what you've already said?
Tryptophan has been used quite a bit, like for in pediatric populations, even absent ASD or developmental disability overlay. Certainly at it's the preferred hypnotic at the Youth Dill Sleep Clinic. Folks are given tryptophan upwards of 15 grams a night. The problem with tryptophan is that it's a very, very big pill.
And I think you have to take a lot of them, don't you?
Yeah, it's just like, because of the sheer size, it's like a meal. So, if they're able to tolerate it, then it's great, because it does work. And in fact, Charlie George at LHSC, at the beginning of his career when he was in Manitoba, he was one of the first guys to write a paper on open label effectiveness of tryptophan in insomnia. So certainly it does work. Problem is that it's a big pill.
Yeah, and I have one patient who I think she takes 3,500 milligrams at bedtime, but that's 7 capsules, and each capsule apparently is very large, her mom said. But that may be a limiting factor for kids. So there's a comment here from a psychologist in the St. Catharines area. Says she conducts sleep intervention as part of her clinical practice and sleep research as well through Brock. But she says that, I guess this goes back to Jennifer's question about parents' receptiveness. And it says that when she is able to explain, sort of sit down and talk at length with parents about their willingness, about behavioral interventions, that she finds people are more willing to try it. But also it points out that it's important to distinguish between cognitive behavioral therapy and applied behavioral analysis, and that perhaps they have a different role in different patients. And I guess that's, unfortunately, for a lot of studies we do, probably across all psychiatry, it's a sort of a shotgun approach. It's one size fits all kind of thing, as opposed to sort of tailoring treatments to individuals.
Yeah, I think part of that is that for the behavioral approaches, there's always a push to have them become manualized so that they're easy to apply at different places and at different times. I think this brings up a great point. It's very important for us to tailor the treatments to the specific needs of our unique patients.
So I want to make sure that we give Dr. Goldberg an opportunity to. Dr. Goldberg had a question, although he's apparently joined us twice. So I'm not sure which one is the correct one, Ben. But anyway, Ben's question was about oral physical anomalies, and I think CPAP. But Ben, can you sort of specify more specifically what your question is?
Yeah. For example, by the way, I'm delighted that Dr. Mack has expanded on his experience with the sleep clinic in London with Dr. George, and now adapting it to the problems of the developmentally handicapped. So congratulations, I'm delighted to hear your review. What I was thinking about was that with Down syndrome, and I also had a Klippel-Feil syndrome, the actual physical structure of the oral mechanism is such that it interferes with sleep. And the Klippel-Feil, of course, had to have oxygen all the time. So that's the comment that I was going to make. The other comment was in terms of melatonin. I tried melatonin many years ago, but I was very concerned about the quality of the melatonin that you get in the nature food stores. I was able to get some pure melatonin when I had a visit to Israel. But as you pointed out, the effect of melatonin really doesn't give you much more than 20 to 30 minutes. So that, those were three comments that I wanted to make.
Yeah, those are great points, Ben. And the interesting thing about absolute improvements to sleep, if you looked at like the initial trials for Zopiclone and how much it improved, like decreased sleep latency, sometimes the average was like minus 10 minutes or 6 minutes and something like that. So I think that the melatonin can be very helpful, especially in young folks, as a blanket rule. For like the breathing issues and needing oxygen, especially like in Down syndrome folks, there's a higher propensity for obesity and overweight in that population. So on top of sleep apnea, which we treat with CPAP or surgery, taking out the tonsils, adenoids, the pillars upon which they sit, as well as parts of the soft palate that hang down towards the back. So that's a uvulopalatopharyngoplasty that Dr. Brian Rotenberg does at St. Joe's. That's helpful for the sleep apnea, but there comes a point when the combination of the obstructed airways plus the overweight and obesity causes hypoventilation, where you're just not ventilating enough and you're accumulating carbon dioxide. So these are concerns that you have to keep an eye out for in that specific population. I saw that there was a question from Dr. Mitchell about clonidine. Yes, clonidine is used for insomnia as well. I've seen trials that show that it's efficacious. In those patients, you just keep an eye out on them, make sure they don't fall.
So the Michael, we only have time for a few more questions, but it's first of all interesting that you mentioned Brian Rotenberg. I don't know him, but the Judge Rotenberg Center in Massachusetts was the last place in the United States licensed to use phoretic stimulation for self-injurious behavior. So questions about is there any benefit to using sustained release versus immediate release melatonin, and when would you use each?
So the sustained release ones, the theory behind that would be that, somehow you're going to keep the person asleep for a longer period. Now, the thing with melatonin is that I'm unconvinced that it has sedative, soporific, hypnotic effects as it exists in the over-the-counter version. I've seen evidence from the synthetic versions where they modify the affinity to MT1 and MT2. So MT1 being what's thought to be the more soporific side of things and hypnotic side of things, and MT2 being the circadian side of things, where it actually knocks you out. For that reason, I would just rather have plain Jane melatonin and just adjust your timing. Sometimes it's going to be 4 to 5 hours before your desired bedtime. Sometimes it's going to be 3 hours before your desired bedtime. In young people, where there might not be any melatonin whatsoever, sometimes taking a bedtime helps them.
So so Nicole Neal, I guess, had gone and quickly looked at her data. So in work that her graduate students have done with children and adolescents with Down syndrome. She reports that 100% of parents report sleep problems. So apparently much more common than I realized. And then we'll say second last question is from Dr. Pryor. At what point would you actually suggest a sleep study? What would have to be going on for you to suggest one? And I guess along with that, like how severe would the sleep problem have to be to warrant that?
I would say that like if you have symptoms of a sleep disorder like sleep apnea, if there's snoring, if there's changes in breathing at nighttime, if there's severe complex sleep behaviors. So like I'm not talking about simple good old like night terrors or like sleepwalking and sleep talking because we know 90% of those go away after age 9. But like if they're persistent, if they occur every single night, if somehow they've injured themselves, fallen down staircase, I think that or if there's treatment resistance, right? You try melatonin, you try behavioral approach, it doesn't work, then we should find out what's going on, because then we'll have the EEG data, we'll have the movement data, and we're correlating it with heart rhythms and all those things. Because increased parasomnias at night sometimes is, and leg movements for that matter, is caused by the presence of like a condition that causes increased arousals from sleep, going from a deeper stage of sleep to wakefulness or a lighter stage of sleep. And oftentimes that's a sleep breathing disorder. In little kids, they've actually shown that just plain old snoring and increased airway resistance, not causing the apnea index to go above 5, which is the clinical definition of apnea, then those patients, that it leads to symptoms of ADHD. It leads to daytime irritability and tantrums. So I think that it's a little bit more nuanced. That in those scenarios, I would want to do a sleep study.
And it's there was a study published recently, I think it was fairly preliminary, looking at correcting sleep problems without stimulants in children and adolescents with ADHD. I think it was sort of a proof of concept idea. And they reported some improvements in behavior during the day. So these are people with ADHD with normal intelligence. But I mean, it wasn't the solution, but it certainly had some positive effects besides the sleep itself.
There's a recommendation that in a child with that presents with an attention hyperactivity or impulsivity, that if there's the presence of overweight or snoring, that the first step actually be sleep study.
And actigraphy, people basically have to buy their own watches.
Yeah, like a Fitbit, like the Apple Watch. Those like the consumer grade ones are obviously they're not as high resolution. They're not capturing as much information as like the research based ones, but they still do a pretty bang on job of finding out when you go to bed and when you wake up in the morning. Like there was an Italian study. They bought a whole bunch of Fitbits from different brands. It ended up, they compared it to like actual actigraphy on the other opposite arm, and they thought it was about 80% accurate. So, the actigraphy just saves you time, because then you're not having to like check the time when they wake up. You're not, having to do intense observation. Like it's going to be in the data itself.
Yeah. So earlier, Michael, I think you said that nobody died from insomnia. So I don't want to correct you, but I think one of the more horrific ways to die is fatal familial insomnia. And I don't know if you're aware of that, but have you heard of it?
Yeah, that's a prion disease.
Yeah, but I think it's people are awake for about 2 years, and then I think it's only been reported in about 30 people. And I think even with general anesthetic, people haven't been able to sleep. And I guess when they've done autopsies, their brains have been mush, essentially, I think, so obviously not sleeping for 2 years is not good.
That's right. I think the very first case was like he was like some fella in Venice of some notable repute, and the guy just couldn't sleep at all. It's a horrific way to pass away, and it's true. Like the use of serious anesthetics, like propofol or whatever, like that, it doesn't really put them out, and they go on to develop psychotic symptoms. They see visual hallucinations, and then eventually stupor and death. But
I think it's only been reported in 30 or 40 people or something like that.
Yeah, it's exceedingly rare, and we're lucky that it's not transmissible.
No kidding. So last question then. I like to believe that I'm one of the greatest sleepers in the world. So what would you say, are there any downsides to sleeping excessively, let's say on the order of 18 to 20 hours periodically?
Absolutely. So in the same way that short sleep time on average causes a higher incidence of overweight, obesity, risk of diabetes, risk of hypertension, and cardiovascular accidents, including heart attacks and stroke, like, if you sleep less than 5 hours, there's evidence that shows that if you sleep more than 10 hours, you also have an increase in those risks as well.
But that's consistently sleeping more than 10 hours?
on a nightly basis.
Yeah, because then you'd wonder also, but I don't know how many people do that on a nightly basis. And so are those people overweight and predisposed to these things anyway to begin with?
You know, you wonder if it's because with the fewer number of active hours awake that you're just not active enough, right? You know, when we're up and about, we're expending calories. When we're resting, our respiratory rate goes down, heart rate generally goes down.
Yeah, because isn't that what happens with people with, is it Pickwick syndrome?
Yeah. Sleep hypoventilation. So obesity hypoventilation syndrome. So like, you know, when we're awake, our drive to sleep is the strongest it can be. As we enter sleep, it decreases and decreases, right? So light sleep, we breathe a little bit less frequently and less deeply as we would while we're awake, and so on and so forth as we go into deep sleep and dream sleep. And with the additional weight, you know, then some folks just don't ventilate enough and they accumulate carbon dioxide, and that can be disastrous.
Okay, so we have to start there. Michael, this was fantastic. And I think the fact that we're still here at 5:30 with unanswered questions, I think attests to the interest that people had in your talk and the value that it provided. So this was phenomenal, Michael. So thank you very much. I don't want to say it exceeded my expectations because that might be rude, but I think it was wonderful.
Thank you. Always my pleasure.
So so our next talk is in January, on January 13th. And I just wanted to remind people not to miss the upcoming great conjunction of 2020, when Jupiter and Saturn will be closer together than they have been in 300 years. And it'll be the most visible that they are together in the night sky since the death of the time that St. Francis of Assisi died 800 years ago. So it's something to look for. And we will see everybody in January. And thank you very much.